Hi, my name's Ted O'Connell, one of the authors of USMLE Step 3 Secrets. This is Case 2 from the CCS cases from this book. Before we get started, please consider taking a look at medicalschoolvideos.com for additional videos and like us on Facebook. History of the present illness. This is a 40-year-old woman who presents to her primary care doctor with 8 months of progressive weakness, dizziness, and fatigue. She states that whenever she stands up, she feels like she is going to pass out and finds it hard to even get out of bed in the morning. She says that despite not going outside much due to her weakness, her skin has been getting darker. She has lost 20 pounds over the 8-month period and states she doesn't have much of an appetite, but her husband remarks on how much salt she uses at the dinner table. She endorses that she is too thin and wants to gain her weight and strength back. She denies any syncopal episodes. Vital signs. Temperature is 36.8 degrees Celsius. Pulse is 60. Blood pressure 108/60. Respiratory rate 16. Additional history. There are no suicidal ideation or homicidal ideations. There is no auditory or visual hallucinations. She has no past medical or psychiatric history, and she denies any alcohol, tobacco, or drug use. What is the differential diagnosis in this case? The differential diagnosis includes anorexia nervosa, chronic adrenal insufficiency, hemochromatosis, hypothyroidism, and occult malignancy. What components of the physical exam do you perform? The components of the physical exam that should be performed include general appearance, HEENT, cardiovascular, and pulmonary exams. Physical exam findings. General, the patient is a thin woman in no apparent distress with generalized hyperpigmentation. HEENT, there is no goiter or palpable thyroid nodules. Buccal mucosa demonstrates hyperpigmentation. Mucous membranes are dry. Cardiovascular and pulmonary examinations are normal. What are your initial orders? Initial orders should include orthostatic vital signs, EKG, CBC, and Chem 8. Advance the clock. Findings on orthostatics are positive. The blood pressure on standing is 80/50 and pulse is 108 beats per minute. EKG demonstrates a normal sinus rhythm. CBC is within normal limits. Chem 8 is remarkable for potassium of 5.5 milliequivalents per deciliter, a sodium of 134 milliequivalents per deciliter, and bicarbonate of 20 millimoles per liter. What are your follow-up actions? Appropriate follow-up actions include early AM cortisol level and fluid replacement. Advance the clock. The early AM cortisol is undetectable. So what are your follow-up actions? This patient should be started on hydrocortisone and fludrocortisone replacement. Advance the clock. The patient feels much better and the case ends. The critical actions in this case include recognition of chronic primary adrenal insufficiency, performing the appropriate workup, including the chemistry panel and cortisol level, and providing the appropriate treatment, which includes steroid replacement. Discussion of this case. This patient has chronic primary adrenal insufficiency, also known as Addison disease. The adrenal cortex has 3 layers: the zona glomerulosa, which makes aldosterone, a mineral corticoid; the zona fasciculata, which makes cortisol, a glucocorticoid; and the zona reticularis, which makes DHEA sulfate, an androgen. Since aldosterone acts to reclaim sodium and excrete potassium and acid in the distal nephron, loss of this hormone leads to hypotension and a hyperkalemic metabolic acidosis. This is a key point, a hyperkalemic metabolic acidosis. Cortisol also has a role in catecholamine sensitization, and loss of this hormone can lead to resistant hypotension. Loss of the adrenogenic hormones is less noticeable. Addison disease is most commonly autoimmune in developed countries, but tuberculosis is the most common cause worldwide. Loss of cortisol production causes increased ACTH levels. One breakdown product of this is alpha melanocyte stimulating hormone, which leads to characteristic hyperpigmentation, especially in the buccal mucosa, genital area, and areola. Symptoms include fatigue, salt craving, memory impairment, depression, and vague nonspecific symptoms. Acute adrenal insufficiency can be seen with sepsis, especially infections from Neisseria meningitidis causing Waterhouse-Friderichsen syndrome. Iatrogenic causes, such as acutely stopping chronic steroids or giving medications that inhibit cortisol production, such as etomidate or ketoconazole, are also precipitating factors. Screening for adrenal insufficiency can be done via an early AM cortisol level. A level over 20 micrograms per deciliter excludes adrenal insufficiency, but very low levels under 3 micrograms per deciliter are diagnostic, and intermediate values require further investigation. An ACTH or cosentropin stimulation test can be undertaken where a basal cortisol level is taken, ACTH is given, and 30 and 60-minute cortisol levels are drawn. A low initial value and low 30 and 60-minute values make the diagnosis of primary adrenal insufficiency. A low initial value and normal 30 and 60-minute values indicate pituitary dysfunction, as the gland is functional. There's a normal ACTH response, but the pituitary is not sending enough ACTH out, or the hypothalamus is not sending enough CRH to the pituitary gland. Management is administration of hydrocortisone and fludrocortisone, with increases of the hydrocortisone dose during illness or before a stressful medical procedure to mimic the body's endogenous cortisol spikes during these times. So the diagnosis for this case is adrenal insufficiency. Thank you for joining us for this video, and please take a look at our other videos as well.